Good afternoon and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore Wiskott-Aldrich syndrome with Dr. Suhag Parikh and Dr. Chandrakasan from Emory University School of Medicine. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. I would like to thank our partner, the Wiskott-Aldrich Foundation, for supporting today's program. We will be hearing from them later on in today's presentation. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists and be able to hear myself and the presenters. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions at the end of the presentation. You're welcome to submit any questions you have for our presenters as you think of them throughout the session. We ask that you please type them in the Q&A box in the control panel at the bottom of your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We're here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes our Patient and Family Handbook for Primary Immunodeficiency Diseases, which includes an entire chapter dedicated to Wiskott-Aldrich. We encourage you to visit the Idf Resource Center, where you can find all IDF publications, videos, news, and more. IDF also offers monthly programming and events. In addition to our Lunch and Learns, we host 2 IDF forums a month, and we also have Get Connected groups, peer support, and Ask IDF. We're also thinking of ways to bring the latest in PI to you, such as the 2022 Primary Immunodeficiency Conference. We hope you'll save the date for this exciting event coming up in the fall, and that will be October 6th to the 8th. All right, now without further ado, I would like to introduce our presenters for today, Dr. Suhag Parikh and Dr. Chandrakasan from Emory University School of Medicine. Welcome.
Thank you, Emma, and thank you, Sumathi, for kind introduction and the opportunity to present the VAST carrier study. Again, this is a collaborative effort between Wiskott-Aldrich Syndrome Foundation, PRTC, our Children's Healthcare of Atlanta and Emory University, and IDF. And myself, I'm Chandrakasan, and Suhag Parikh, both are immune deficiency transplanters, and we run the immune deficiency dysregulation program at Emory University. And I'll be presenting some background slides, and Dr. Suhag Parikh will go over the survey data. Without much delay, let me quickly run through some background information, and then we will discuss the survey and potential opportunities for future research. Again, for this audience, we don't need to go too much into what Wiskott-Aldrich syndrome is, an X-linked thrombocytopenia. Needless to say, this is an X-linked combined immune deficiency with a genetic defect in WASP gene. The classical Wiskott-Aldrich syndrome, which is the more severe phenotype, is characterized by thrombocytopenia, infection, eczema, increased risk of autoimmunity, and malignancy. A slightly milder version of this disease, known as X-linked thrombocytopenia, has been characterized by thrombocytopenia eczema, though it was initially turned to be milder. But as we know now, as we follow these kids longer into their second and third decade of life, we realize that increasing proportion of these patients have equally severe autoimmune risk and also increased risk of malignancy. And there is a well-regarded scoring system how to characterize them as X-linked thrombocytopenia or classical Viscott. Again, going by the similar theme that the thrombocytopenia and eczema are the initial presentations for most X-linked thrombocytopenia. In a classical Wiskott-Aldrich syndrome, there is significant immune deficiency and also risk of infection. And in both this group, there is increased risk of autoimmunity and malignancy. A classical XLT, initially, at least in the first decade, most of them score a 1 or 2. And a classical Viscott, because of increased risk of infections and immune deficiency underlying, typically score a score of between 3 to 5. And once they develop significant autoimmunity or malignancy, they get upstage to a score of 5. That's a severe spectrum of the disease. So what does Wiskott-Aldrich syndrome protein do in our body? It's a very critical immune function gene. The expression of this protein outside of the immune system is very limited. In the immune system, it has several critical functions. As you can see in this cartoon, it's critical for immune synapse. Immune synapse is a way in which the immune cell communicates with a target cell that has an infection or another immune cell so that they can crosstalk and come up with an immune plan to attack an infection. They're needed for immune cell migration because they need to go to the site of infection. A defect in Wiskott-Aldrich syndrome protein function can make the migration difficult for the cell. They're also needed for cell-to-cell communication and within the cell communication. Like if a cell gets certain signals, it needs to process it and act accordingly. If the intracellular trafficking becomes defective, then they cannot process the signals well. So that results in the cytokines or chemicals that immune cells secrete to tell other immune cells what to do. If there are problems here, the communication becomes disrupted. They can either lead to both immune deficient signals and also autoimmunity. And similarly, transcription regulation is a critical intracellular function of any given cell. If that is abnormal, the cell functions differently. And the phagocytosis, as you know, is critical for infection control. So as you can see, a single protein can have a multitude of function. And in Wiskott-Aldrich syndrome, if this protein is defective, it leads to profound T and B cell immune deficiency. And recently, in addition to the immune function of Wiskott-Aldrich syndrome, there is a non-immune function. Its role as a tumor suppressor has been increasingly recognized. And that also adds to the risk of malignancy we see in these patients because of, in addition to immune deficiency predisposing to viral infections and that increasing the risk of malignancy and autoimmunity, its role as a tumor suppressor in the deficiency state, it can also promote malignancy in some of these patients. So we have been for a long time studying the immune defects in patients with Wiskott-Aldrich syndrome. I think thanks to several investigators over the last 50, 70 years, we have a very good understanding of what is the underlying immune problems in most patients with Wiskott-Aldrich syndrome. Excellent supportive care and improving curative options are leading to overall improvement in survival of patients with Wiskott-Aldrich syndrome. But for every patient with Wiskott-Aldrich syndrome or XLT we identify, there are likely to be more carriers that either are actively screened or not screened yet. So they could be mother or sister of a patient. You could identify maternal grandmom or aunts. So for every patient, there is likely to be more than one carrier that is out there, either diagnosed or non-diagnosed. So it comes to this theme of, we have been all talking about Wiskott-Aldrich syndrome, but it almost goes to the theme of this recent Disney movie Encanto, in which we don't talk about Bruno. We don't talk about carriers as much. These are a dominant force. There are a lot more carriers. I think it's very important to start talking about Wiskott-Aldrich syndrome carriers as a separate entity and try to do targeted studies and understand the problems they face in a more methodical way. And the carriers of X-linked immune deficiency like Wiskott-Aldrich syndrome are not alone. There are several X-linked immune deficiencies I've listed here. Some of them are milder. Some of them, the carriers have much more problems. For example, there is an active study going on with X-linked CGD. Along with this Wiskott-Aldrich syndrome study, there is a sister study that has been going on with hyper-IgM. And there are several other immune deficiencies that are also X-linked that needs further exploration to say, do we really know the carriers of these X-linked immune deficiencies are healthy or not? What specific immune problems happen to each of these carriers? And that's where a disease-specific survey for each of these carrier state is critical. And both for the family and also for physician, there are several questions that are in mind. Do carriers have immune problems? If the immune problem, what is the risk of infection? Is there autoimmune problems or similar to what we see in patients? Is the risk of eczema in these carriers? Do carriers have bleeding issues due to platelets? Do carriers have a increased risk of malignancies? Are there any specific risk during pregnancy for a carrier? Or are there unknown risk factors that we are not even aware of, that we are not even thinking about? Because most Viscott, again, Viscott classically happens in the male, and in carriers or female, does hormonal things have any effect on this disease presenting a little bit differently in carriers when compared to what we see in boys or men? What is the effect on mental health and quality of life between all the caregiving and also their own immune issues that they are dealing with? So before jumping on to the specifics of it, we thought we'll spend a couple of minutes on what is this term lionization. For a carrier, they might have heard about it either in one of the medical discussions, if they had a discussion with medical counselor or with their physician. So as we know in women and girls, we have two X chromosomes. And here in terms of color code, for simplicity, let's take the red X chromosome as the one that has defective Viscott gene. And the blue is the one that has normal copy of Viscott. So one comes from mom, one comes from dad. So in a random way, it's thought that in humans, there need to be only one X chromosome that needs to be active at any given time. So the body decides to inactivate one X chromosome randomly. If this happens in a random fashion, you will have 50% of the cells that have the defective Viscott protein and 50% of the cell that has normal Viscott protein. But due to some unknown reasons, there are several speculated reasons, and there are some proven. Sometimes body decides to skew towards one. They prefer one copy of the X chromosome and compared to the other copy. If it happens if the body prefers to use the defective X chromosome that has the defective Viscott protein, then you can have a situation in which there's 10% of the cells have normal Viscott and 90% doesn't have Wiskott-Aldrich syndrome protein. So that is one step in determining what happens to the immune compartment of the carrier. But the other important step to understand is, because the deficient cell, the cell that is deficient in Viscott protein, cannot compete as well with a cell that is replete with Wiskott-Aldrich syndrome protein. So especially this is important in T cells, B cells, and NK cells, where the cells that have normal Viscott protein have a survival advantage. This is like a healthy sibling, weak sibling, and survival of the fittest in play. After the lionization has happened, after the cell is formed with a Viscott deficient Viscott replete protein, the cell that has the Viscott replete protein has a survival advantage. So despite a skewed lionization, there is a huge selective pressure for normal cells that have normal Wiskott-Aldrich syndrome protein. So this actually works in the favor for carriers in that even if genetically the makeup is such that in a carrier, they are skewed towards the deficient population, their T cells, B cells, NK cells still preferentially show the cells that have normal Wiskott-Aldrich syndrome protein. Thus, most carriers still have relatively normal T, B, and NK cell compartment. this can be again further illustrated, the lionization could be further illustrated by a nice example here of Calio cats, in which the fur of the cats is determined by the X chromosome. There is an X chromosome that gives an orange color. There's another X chromosome that gives a black color. So, and if this is a random event, depending on how random this is, you can have a cat that is a good mix of orange and black. But if the lionization is skewed towards orange, then you see cats that are more towards orangish hue, and there are cats that are more towards black. So you can think of similar things happening within the blood compartment, in which depending on which gene the cell favors, which X chromosome the cell favors, then you can have an immune compartment that is a deficient compartment versus immune competent compartment. And based on these, there have been several examples, predominantly case reports of Wiskott-Aldrich syndrome in women, in girls. But as you'd realize, the early reports, early 1990 reports, are prior to identification of Wiskott-Aldrich syndrome gene. Even though Wiskott-Aldrich syndrome as a disease have been identified since 1954, the gene for Wiskott-Aldrich syndrome was only cloned in 1994. So the prior reports before this or around this period did not have a genetic confirmation of Wiskott-Aldrich syndrome. So they're predominantly based on additional supportive data rather than true genetic confirmation. So some of these reports initially we think could be truly, there is another form that exactly mimics Wiskott-Aldrich syndrome that is due to Wiskott-Aldrich syndrome interacting protein called WIP, and that is autosomal recessive. And some of these are thought to be truly autosomal recessive WIP deficiency, not Wiskott-Aldrich syndrome. But not deviating too much from our topic, there are truly girls, women with X-linked Wiskott-Aldrich syndrome described in literature. This is a small snapshot. There are several more case reports, but these are reports with rare examples in which they're talking about extreme lionization, in which instead of doing a random 50-50, they're, while in the early stage of development and later on as the immune system develops, as the stem cell develops, somehow in their developmental phase, the normal copy of X chromosome that has X normal Viscot copy got inactivated, and predominantly the defective copy was the only active copy in these women. So this is illustrated by a classical case presented in NEJM in 1998, in which they noted the parental Wiskott-Aldrich, the parental copy of the X chromosome that had a defective WASP protein, WASP gene, was the only one that was active. The maternal copy that had a normal WASP was inactivated. And this led to this particular girl having significant thrombocytopenia, IgA levels that are high, IgM that are low. Even if you look closely enough, this is not the severe Viscot. This would be in many situations classified as a X-linked thrombocytopenia. So even in this extreme situation, many girls, if they're reported to have Wiskott-Aldrich syndrome or X-linked thrombocytopenia, many of them tend to be more on the XLT spectrum. But the goal for today is, in addition to discussing the extremes of spectrum, how in extreme cases of lionization, we can have a carrier female have more symptoms. Our goal here to discuss what happens to the majority. We can talk about 5% of them, 10% of them having extreme lionization. We also want to know what's happening to the rest of the carrier as a whole. So why studying all Viscott carrier is critical rather than focusing on the extremes who have problems. I think it's time we start focusing on the health and well-being of the carriers. Not only there because they are the primary caregivers, but also they might have genuine immune concerns that needs to be addressed. And increasingly, transplant, as we know, is moving towards less and less conditioning. with the goal to decrease the toxicity of the transplant process itself. And there is also increasing gene therapy and gene editing approaches that are in the pipeline. I know there has been some recent hiccups, but these are strategies that are still going to be our future. So within that, we are seeing more and more of patients with what we call mixed chimera. Mixed chimera is if a patient gets less chemo, there is a possibility that they have a bunch of cells that are donor cells, and there is also a bunch of cells that are patient-owned cells. So if you study the carrier who are already having this normal protein expression and defective protein expression, that is the closest we can understand what is the amount of chimera we need to have a near normal immune function. As we know currently, both in gene therapy and gene editing, we are at least currently with the technologies we have, we're not close to becoming 100% Viscott expression. We're still going to have a 50-50 scenario or 30-70 scenario. I think studying carriers across the spectrum of Viscott expression at 30%, 70%, 90% will give us a very good understanding of at what threshold we are able to safely say there is very minimal risk of autoimmunity. At what threshold we are able to say the immune system is good enough. I think these things can be only understood by studying carriers. That is the best form of nature's way of showing how gene therapy or gene editing or reduced intensity transplants can work. And the next question that many ask is, the sibling transplants is still the gold standard for several immune deficiencies. So that comes up not infrequently in Wiskott-Aldrich syndrome, wherein we have a sibling donor who's HLA match, but is a carrier. So studying, even though we already have some information that because of the skewing and survival advantage of the Viscott expressing cell compartment, many siblings might be okay, but because a donor is cells are going to be in the sibling for life, we need to know what is the health status of the carrier, not only at the present state, but what happens to them when they're 50 years, what happens to them when they're 60 years. So we need to know them over a lifetime. I think studying carriers can give us that information so that we can come back and either definitively say, yes, carriers are a good donor option. We have done that in other immune deficiency. Our group with Dr. Parikh and Hyper IgM Foundation published that on CD40 ligand. I think a similar study on this group of carriers would also make us even more confident when come up with the situation, are we doing the right thing? And lastly, we don't talk about this that much, but again, the Wiskott-Aldrich syndrome as a disease have been studied in Mayo because it's a disease of men and boys. So we really don't know in carriers, the hormonal milieu is very different from what a boy or a male hormonal milieu is. We know there are certain autoimmune disorders like lupus tend to be higher in women when compared to men. So given some immune defects, will they behave differently in a setting of a female hormonal milieu or not? I think these are unique things that we can only know if you study. Otherwise, we will still keep speculating. So I think there are several reasons why studying carriers, both for understanding their well-being and also help us better inform what strategies we can offer to patients. There are several reasons to study. And part of that is we need to start somewhere. I think that's where we are very excited to share this data of the survey data that Sumathi along with IDF, PITC have put together, and to identify the disease burden, identify the area of future research, and advocate resources for managing carriers. And as a second step, once we identify all this, then in parallel or follow up to the survey, to do a focused immunobiology study to try to understand it in much more depth. I'll pause here and have Dr. Suhag Parikh present the most anticipated survey data.
So thank you, Shan, for giving a brief background on the importance of knowing more about the situation, both medical and psychosocial situation with the Wiskott-Aldrich syndrome carriers. So as Shan mentioned, This survey is a collaborative effort between investigators at PIDTC, especially Dr. Hans Ochs, Dr. Mort Cowan, Jennifer Park, etc. It also involved Sumathi and the Wiskott-Aldrich Syndrome Foundation. There was input from Immune Deficiency Foundation. And we, Shan and I, we worked with the IRB at Children's Hospital of Atlanta to get this protocol approved here in the US. And Dr. David Hagen worked with his IRB in Tel Aviv to get this approved for survey takers who were outside of the US. This, along with the Wiskott-Aldrich Syndrome survey, we collaborated with Hyper IgM Foundation, with Akiva, and there's a parallel, very similar survey, which was also conducted simultaneously through the Hyper IgM Foundation. And as Shan highlighted the importance of studying a variety of X-linked disorders. So this is right here an example. So this study we labeled as a study assessing the physical health and psychosocial well-being of female carriers of Wiskott-Aldrich syndrome. And X-linked hyper-IgM syndrome was the sister study. So this was a self-reported survey, and it has some limitations, but this is still very, very important information. And what we are going to present today is only preliminary descriptive data, because the more detailed correlative analysis, and there's also a lot of text information, which is very valuable, and that is a qualitative type of analysis. So both those more detailed analysis are ongoing. We did not have final data on that, but we are hoping to get that information in the next few months. The objective of this study, the main objective was to assess the medical burden of Viscott carriers. And this included several medical aspects, but most importantly, thrombocytopenia, the autoimmune disorders, infections, and risk of malignancy. And we were also interested in exploring the psychosocial impact of being a carrier in terms of the level of anxiety, depression, worry, and guilt that the carriers face. In addition to this, we were interested in putting forward this information for medical professionals to be more aware of, and so that they can help the carriers better. We also wanted to help develop some guidelines for carriers and physicians based on the information of this survey. And lastly, as Dr. Shan mentioned, we wanted to see if there were patients or carriers who had been donors, and then that would be something to further pursue in the future as regards what kind of transplant outcomes we achieved with these donors. So the design of this survey involved several questions, and this table tells you the categorization of the questions, but broadly they include some information about the relationship of the carrier to the affected individual with VOS. There were questions related to demographics, and then there were lots of questions related to the actual medical burden, which included the symptoms of that the carriers experience or any disease that they were diagnosed with. And then with a more focus on relevant topics such as infection risk, allergy risk, autoimmunity and thrombocytopenia, risk of cancer. In addition to the medical questions, we also included several questions that addressed some of the psychosocial aspects that we were interested in. So in total, we had 68 questions included in this survey. And this is, we are very proud to say that almost 200 individuals participated in this survey. This Wiskott-Aldrich syndrome is a rare disease. The incidence is like 1 to 10 in a million. And while the carrier population is likely to be larger, but still, in general, it's a rare population that we are talking about. And to have 193 survey takers I think it speaks volumes of the effort put in by various individuals, in particularly Sumathi and IDF. So we are very grateful for their efforts. So here is some demographics. The survey takers, as you can see, were about split between US and outside the US. About almost 50% of the patients who took the survey were outside of the US. So this is truly an international survey. And majority of the survey takers reported themselves to be white. As far as the age of the survey takers, the median age was about 39 years with a range from 20 to 74. But as you can see from this bell-shaped curve, majority of the patients were less than 50 years old. The question we asked was, what is your relationship to the individual who is affected with WAS? And as you can see, 83% of the survey takers were mothers of affected sons. There were about 17% of them who were sisters or daughters, and there were a few who were grandmothers and aunts, but mothers were the predominant group that participated in this survey. And about 30% of the participants had more than one affected individual with Viscott in their family. Another question that was asked was, what is the severity of Viscott in the affected members of the family? Is it classic or severe, or is it mild, or is it both? And you can see that about 69% or majority of the participants reported that they had severe Viscott in the family. And about 18% reported that they had mild Viscott or X-linked thrombocytopenia in the family. And there were a certain percentage, a small percentage who had both in the family. So it's unclear why there is such a predominance of classic Viscott in this survey participants, because in the literature, it's about half and half, the incidence of Viscott and classical Viscott and X-linked thrombocytopenia. But this is a self-reported survey, and this is not a prospective randomized type of clinical study. So there may be some biases or in the population who participated. It is also possible that the participants might have some difficulty in figuring out whether the situation in the family is severe versus not, because even the doctors sometimes have that problem in figuring it out. So it's not an easy thing to do. But regardless, I think this gives you an idea that's fair amount of severe Viscott in the community, and this information represents those families. So this slide shows a global view of the medical burden through some of the questions that were asked about symptoms that the carriers were having. And what you can see here in this figure is on the left side, you have the patients who did not have these symptoms, and on the right side in this dark blue, you have patients who had the symptoms. And the taller peaks represent the most significant symptoms. And what you can see is there were a lot more symptoms reported in the blood system, the joint system, and the skin system. We also asked about specific diagnosis, not just symptoms, but specific diagnosis. So you can see that there were a lot more symptoms reported, but as far as the specific diagnosis, there were fewer. But nevertheless, there were reports of endocrinological problems and gastrointestinal problems in fair numbers. And we will further go into these details in the next few slides. So one of the triads of Wiskott-Aldrich syndrome is thrombocytopenia. It's one of the main symptoms of, or one of the main element of the diagnosis of Wiskott-Aldrich syndrome. And what you can see here is that about 12% of the patients reported that they had platelet counts less than 150,000. But also 2% of them had platelet counts which was less than 50,000. So this is a very severe condition when you have platelet counts less than 50,000. There's a risk of spontaneous bleeding when your platelet counts are less than 50,000. So I think that this information is important to know. In some ways, it's reassuring that not many more carriers have profound thrombocytopenia, but it also probably is it is also possibility that if you check the blood counts of the carriers more broadly and longitudinally, you might find that these numbers might be actually higher. So therefore, there is a need to study the carriers prospectively, more comprehensively than the information that can be provided in a self-reported survey. And then whether these platelet counts were low transiently or on a more long-term basis is another important question that is meaningful. So we asked the question about whether the platelet counts were low over a period of 3 months or more, and 3% of the carriers reported that they had this type of chronic thrombocytopenia. And again, most of the patients, most of the carriers do not get repeated platelet counts. So this number may also be an underrepresentation of the actual problem. Most of these carriers were diagnosed at a relatively early age, between 20 to 30 years. And at least in this particular survey, about 3% of them reported that they needed intervention, such as IVIG, platelet transfusion, or steroids to address the low platelet count. The next important aspect of Wiskott-Aldrich syndrome is skin problems, especially eczema. And so this question about the skin problems is not surprising. We see a fair amount of respondents saying that they had eczema, about 22%, or 1 in 5, at least. And because of the platelet counts being low, even though the incidence of thrombocytopenia was only 12% or so, but there's a lot more easy bruising, again, highlighting the fact that maybe many of the carriers may not have had platelet counts monitored and they didn't know that they had low platelet counts. But easy bruising is not generally seen unless your platelet counts are low. The third important aspect of Wiskott-Aldrich syndrome is immune problems, combined immune deficiency or immune dysregulation, or increased incidence of allergies. So this question about allergy shows that there's a fair amount of allergy burden in this group. For example, 18% had allergy to drugs, 10% had food allergy, 34% environmental allergy, and asthma was seen in about 17% of the carriers. Overall, 49% or nearly half of the carriers reported that one or more allergies. And we also asked about infections. You can see that there was a fair amount of sinus and ear infections, and also skin infections. There were a few infections reported that typically we don't see in individuals with normal immunities, such as shingles or EBV, CMV. So it is possible that there is some level of more profound immune problems in the carriers. But again, in a self-reported setting, it is hard to tease that out. And one more point to make in favor of studying carriers more comprehensively. Autoimmunity is another important component of Viscot. So 25% of the participants stated that they're autoimmune disorders, and the three most common ones were thyroiditis, rheumatoid arthritis, and immune-mediated thrombocytopenia. There were 4% of the individuals who also described having psoriasis. Regarding the risk of cancer, about 20 carriers out of 193, which is about 10% of them, reported having cancer. The cancer was diagnosed at a median of 41 years of age, the range of 22 to 56 years. And the three most common cancers reported were breast cancer, skin cancer, and thyroid cancer. What was interesting was that we did not notice any description of lymphoid malignancies, which would be more expected in this setting because it's an immune dysregulatory state. So I think that is in some ways reassuring. The incidence of 10%, especially in breast cancer, does not appear to be significantly increased compared to the general population. So overall, I would say this is reassuring information. So besides the medical aspects, we also wanted to look at the psychosocial aspects, and some of the questions probed into this. So for example, we asked about the impact on functioning, day-to-day functioning at work, at home, and 60% of the participants said they had some difficulty, and 3% actually said they had extreme difficulty. One of the other things that comes up in this situation is the guilt of passing the gene to the next generation. So 91% of the carriers reported having guilt about passing the gene to the affected sons. And of these, 2/3 felt that they had moderate to great amount of guilt. With regards to passing the gene to daughters, wherever this situation applied, about 88% of the mothers reported feeling guilt about passing the gene to the daughters. And then we asked questions related to healthcare services, and about 15 to 30% of the carriers felt that there were some issues, either where their concerns were not heard adequately by the physician, or they did not receive appropriate counseling for future pregnancies, or to guidance about genetic testing of their daughters. So I will stop there. Like I said, the more detailed analysis is ongoing, and we will be happy to update in a few months when we have more results. But I will now let Dr. Shan come back on and conclude with the last few slides.
Thank you, Suhag. Again, the survey, as Suhag pointed out, has given us a lot of pointers towards what we might need to focus on. But I think it'll be even more informative if we combine that with some degree of immunobiology studies. In addition to doing genetic testing for assessing carrier status, I think a lot more could be learned by doing additional immunobiology studies. What do you know? What are we talking about immunobiology studies? I think Dr. Gilani in Italy have already done extensive survey of carriers, predominantly looking at the immune profile and Viscott expression patterns within different cellular immune compartments. So what we are hoping in her cohort, again, I don't want, she had a beautiful presentation, one of the Viscott lecture series in which she presented data showing about 10% of the carrier have a very skewed Viscott protein expression, even at a stem cell level, and that results in both cytopenias, especially thrombocytopenia, and maybe some immune abnormalities. So, but what we are looking at is to expand that work and do it in a more broader multi-ethnic carrier population in US, and do more comprehensive evaluation of Viscott expression in different immune compartments. Can I have the next slide? So what we have set up as a part of one of the main focus in our lab is to study X-linked carriers of different immune deficiencies. In addition to this, we have ongoing study in both X-linked hyper-IgM and also X-linked CGD. So we have recently set up these assays to also study Wiskott-Aldrich syndrome carriers. And we have validated these assays to check for Viscot protein expression both at stem cell level and not looking at T cells as a whole, but looking at T cell at different cellular immune compartments. What is its role on T regulatory cells? What is its role on T follicular helper cells? And similarly, looking at different B cell subcompartments. The previous studies have looked at these compartments as a whole. So there could be additional insight that we can get by studying these subcellular compartments within the T and B cell compartment. Can I have and also, we know there is a huge advantage to the Viscott expressing compartment in carriers in the NK cells, T cells, and B cells. But what is also of interest is to see what is happening on the myeloid cells, what is happening in the neutrophils, monocyte, dendritic cells. These are lineage-wise different from the lymphoid lineage that you see in TB and NK cells. As an illustrative example, I put in a Viscott expression of healthy control, Viscott carrier, and Viscott patient. As you can see in T and B cell compartment, the carrier and healthy control Viscott protein expression in terms of percentage of cells expressing Viscott protein looks very comparable. They look exactly overlapping. Whereas deficient is very different. It's lower than what we see in carrier or healthy control. Where you start seeing difference in carrier is in the myeloid compartment monocyte. This particular carrier is already skewed in that almost 80% of the myeloid cells express Viscott protein. There is a small hump here that is a negative fraction that you can see in a carrier having about less than 20% myeloid cell having no Viscott protein, another 80% expressing Viscott protein. We have assays to also assess this in platelets. So we can globally assess across different immune compartments and also stem cell compartment. What is the Viscott expression profile? And as noted earlier, even though the flow studies are helpful, we still need to do genetic confirmation of Viscott carrier state. We cannot rely on just flow to know someone is a carrier or not. If the one that can get closest to a carrier determination is looking at Viscott protein expression monocyte. But again, we would not recommend making big decision based on just the flow study alone. Next slide. So in addition to those studies, what would also be very insightful is to look for T cell dysregulation and deficiency by molecular studies that would include flow cytometry, and looking for also B cell dysregulation and signs of B cell maturation problems. Looking at what are any signs of immune inflammation milieu is different in the carriers or not. Obviously, all this will be compared to healthy controls. We'll try to match them for age. So we have an additional healthy control protocol where we have access to healthy women and also girls to compare the profile we get. And we'll also be looking to see what the immunoglobulin profile is, quality of the antibody by checking vaccine titers, and markers of autoimmunity looking at autoantibodies. So all this in combination with the survey data will make our understanding of what is going on in a carrier more robust. Currently, we have this as a IRB approved study. We could at least start piloting this data with once we discuss with Sumathi and work out the logistics. We can start doing these type of studies in a more systematic way. Maybe a year from now, as a follow-up to study, we might have additional information to present and discuss that is much more definitive. This is an example that we have just published, working with Hyper IgM Foundation. We have worked on identifying the immune dysregulation and immune deficiency in patients with in carriers of X-linked hyper IgM. What we noticed is not only by history, but immunobiologically, the carriers of excellent hyper IgM, their immune status is very robust. And even used as a donor for stem cell transplant for their siblings, they resulted in excellent immune function. There are more nuances to it. I don't want to waste your time, but I wanted to show this is feasible. It can result in meaningful outcome changes for patients. So similar line of work can be done with Wiskott-Aldrich syndrome. So in conclusion, again, high proportion of Wiskott-Aldrich syndrome carriers have significant medical problems, both in terms of thrombocytopenia, eczema, infection, autoimmunity, and malignancy. Psychosocial stress is reported or in high proportion of carriers as well. And again, the comprehensive prospective studies of carrier are needed to further characterize the clinical disease burden, understand the immunobiology of the Viscot carriers, eventually helping in developing guidelines for health screening and prevention approaches. Big thank you for both Wiskott-Aldrich Syndrome Foundation, IDF, AATC, and Sumathi, and for all the participants, right? This is not possible without all the robust participation that you all had. We'll pause here, and both Dr. Parikh and I will be happy to answer any questions.
Wonderful. Well, thank you so much, Dr. Parikh and Dr. Chandrakasan. I'm going to go ahead and reshare my slides. All right. Thank you so much to you both. We so appreciate you putting together this wonderful presentation. Before we dive into Q&A, we will now hear from Sumathi Iyengar, President and founder of the Wiskott-Aldrich Foundation. Welcome, Sumathi.
Thank you, Emma, and thank you to IDF to have this session. We just closed the study about a month ago, a little over a month ago, and it's great to see the results. And thank you, Dr. Shan and Dr. Parikh. This was great to hear the results of the survey. Dr. Parikh has already thanked all the people who have contributed, Dr. Hans Ox, the PIDTC, others. I do want to thank all our WAS community for pushing for this survey. All the moms out there who kept telling that we are having problems. Thank you for pushing us, and thank you for taking the survey. This wouldn't have happened but for the fact that you all pushed, and you've been pushing for a long time. I also wanted to say thank you to several of our members, some of whom are our board members, who have beta tested, who went through the survey in detail, making comments and questions. I'd like to call out, and I won't take much time because there's not much time for Q&A. I'd like to call out for Udaya Kedar, Paige Welburn, Amy McNally, Tessa Decker, and Christina Mangurian, who helped us with the guilt section and the psychosocial section. Hers was an important part of that. Brenda Katz and Apurva Iyengar. I also want to say a big thank you to Kiva, who from the Hyper IgM Foundation, without who all of this would have been much harder, and David Hagen, without who we would not have had international participants in the survey. Thank you once again to Dr. Parikh and Dr. Shan for taking this on and for doing the survey, and thank you for planning the next steps of the survey. With that, I'll hand it back to you for Q&A. Thank you.
Wonderful. Thank you, Sumathi. All right, so we have some great questions already lined up in the box, so we'll go ahead and get started with Q&A. All right, it looks like one of these is a two-parter, so I am gonna read part one and then part two. All right, are the girls expressing XLT expected to be prone to autoimmunity and malignancy?
I think that part of the survey need to be teased out further. Again, the XLT, the less severe reported as a smaller fraction of the entire survey. As Dr. Parikh pointed out, most of them, I think 68% of them reported they are carriers with a index family member having severe Viscot. Right now, there is not any data to say they don't, but I think that's where a more formal longitudinal study would be helpful to answer that question. I'll I'll have Dr. Parikh take it to see if there is any specific signal they saw. I don't think we have analyzed it in that way, but I'll have him discuss that.
Right, right. So obviously this survey is a self-reported survey, and it is limited in that fact that it's self-reported survey. We do not have a granular immunobiological data. And this is a cross-sectional, it's a snapshot. We don't have longitudinal information. While most of the patients are around 30 to 40 years, whether this will be more problematic as they get older. So those are the kind of things which would require further study. So at least from this survey, it seems like the incidence of problems, if you were to average out all the symptoms, the disease, etc., is somewhere in the range of 10%, 15% or so, which is less than what we found in the CGD survey, for example. So while I think that there is some potential for girls to have this type of problems, it doesn't seem to be a huge problem. At least that's my impression, but something that needs to be studied. And like Dr. Kedar had pointed out in the text message, which didn't transfer to this Q&A, he asked about whether we had controls, normal controls. And I don't think we didn't have normal controls. It would be very difficult to move on with that study. But ideally we should have a normal control to see how much more of a problem this is compared to the normal population.
Thank you. And then kind of part two of that question is, how often should a carrier's immunobiology be tested or assessed with that array of things to monitor, meaning autoimmunity and malignancy?
That's a great question. I think currently there is no standard. What we are hoping to do is to at least cross-sectionally evaluate them so that we know what to expect. If you find everything to be totally normal, then I think as we study this carrier across age group, for example, if you find when they get to 50 and 60, there is more proportion that have both autoimmunity and immune deficiency or thrombocytopenia, maybe there might be at the early age group, maybe you can do once in 5 years. But as we get older, those are things we need to, I can't speculate. Once we do a more formal study, if you start to see at certain age group, these things become more prominent, we can recommend a more closer monitoring at that age group when compared to when they are 10 years of age or 20 years of age. So even if we get a cross-sectional cohort of 50 carriers across different age group, that will give me a very good idea as to how these guidelines can be developed with time.
Wonderful, thank you. I just want to make a note. I realize we're coming up on 2 o'clock, so we understand if anyone has to drop off, but we have a couple of more questions here for Q&A, so we'll be sticking around if you care to stay with us. All right, next question. Someone asked, so it says nearly half of us carriers have environmental allergies. How does that compare to the general population?
So I think that the environmental allergies are quite common in the general population. So I am not sure how much more than the general population this is. I would say that it is about 30–40% in the general population. So it doesn't seem to be very much increased compared to the general population. This is really where a control group would have been helpful, but that is a limitation of our survey.
Thank you. All right, next question. Do you plan to stratify the results into respective groups, meaning mild versus classic? I ask because I wonder if the carriers of classic variants, either null or severely affecting the function of the protein, are less likely to have manifestations due to preferential skewing and X activation.
Yes, we definitely. So that's what I meant by correlative analysis. So we do wish to use these factors such as age and severity of the disease in the family, thrombocytopenia, and some of the other manifestations. We do use those to stratify. That analysis is ongoing.
Thank you. All right, next question. Do WASP patients have a higher risk of infection compared to other immune deficiency patients, such as Cbid? If so, how do you manage their risk of infection differently?
A classical WASP, usually the Cbid, again, these days we have genetic diagnosis for Cbid cohort 2, like it could be the Cbid as a group that we know of is now already 50 different gene defects. So I think each of them might have a slightly different risk of infection, and it depends on what is the degree of T cell dysfunction we see in Cbid. But a classical Viscott we know is a combined immune deficiency in which there is both T and B cell defects. So we expect to see infections very early in life if it's a classical Viscott, whereas most Cbid tend to be in the later half of their first decade or second and third decade of life. So within that, a classical Viscott, once we diagnose, they are on prophylaxis right away. We don't wait around. Whereas in Cbid, many times we see what is their T cell profile, what is the B cell profile. If the T cell profile looks good, if they're predominantly just antibody deficiency, they're only on immunoglobulin replacement. Whereas a classical Viscott, in addition to immunoglobulin replacement, there is likely to be antiviral, antifungal prophylaxis that is added very early on. So I think these two are very different diseases. Even though both are immune deficiency, the risk of infections could be very different based on whether the Cbid is more like a combined immune deficiency versus purely an antibody deficiency.
Wonderful, thank you. And thank you so much to our audience for all this engagement and all of the questions. We really appreciate it. This will be our last question. Just want to read one more. Can female carriers who choose to have a pregnancy carrying a WAS-affected male find out what type of WAS the male baby would have?
I'm sorry, I missed that question. Sorry, can you?
Sure, no problem. Hold on, where did it go? Can female carriers who choose to have a pregnancy carrying a WAS-affected male find out what type of WAS the male baby would have?
Okay, whether it's going to be an XLT or severe Viscott, that's going to be difficult. I think it's only after birth, the immunophenotyping and how the profile looks is what is going to decide, because there are certain genotype-phenotype correlation. Certain genetic defects have a slightly milder phenotype. Outside of that, a given gene defect can present. We have had situation where a same genetic defect, even within a family member, can have both a classical Viscott and also an XLT type of presentation. So I think, so those things is going to be determined outside of genetic results alone. After birth, looking at the immune profile is what is going to dictate whether that particular baby is a classical Viscott or XLT. Suhag, feel free to add.
Yeah, no, I think the genotype phenotype correlation, there is some information, but it can never be so definitive. So in utero, yeah, certainly diagnosis can be made and we can get the exact genotype, but how much to, believe that, and especially if you're going to make a decision based on that, is very tricky because like Shan said, it can be very variable. The knowledge about genotype phenotype is evolving and it's really by no means considered definitive.
All right, wonderful. Thank you so much again to everyone who submitted questions. We really appreciate you. And again, thank you so much, Dr. Parikh and Dr. Chandrakasan, for putting together this wonderful presentation. We truly appreciate it. To our audience, if you have additional questions, we encourage you to ask IDF. I know we had a couple other question askers in the box there at the last minute, but we definitely encourage you to ask IDF. Go to www.primaryimmune.org/ask-IDF and enter your questions, or give us a call at the number on your screen. In the meantime, we hope you'll take advantage of all the resources that IDF has to offer. To explore our resources for Wiskott-Aldrich, visit our website and search WAS in all caps or Wiscott, or visit the IDF Resource Center. We have everything from videos of past presentations, such as the one today, to stories from real patients on our IDF YouTube channel, and we even have podcast episodes about WAS specifically. And here's a couple other examples of WAS resources that we have to offer. And finally, we want to close by saying that all IDF programming is truly guided by the individuals and families we serve in the PI community. So we hope that you will take a moment to scan the code on our screen and take our very brief program evaluation survey. This will also be sent out to everyone after the webinar. Lastly, we hope you will join us for our next IDF Lunch and Learn, part of our SCID Compass series, where we will take a look at the importance of long-term follow-up for SCID with Dr. Morna Dorsey from UCSF. That will be coming up on May 18th. All right, well, thank you so much again to Dr. Parikh and Dr. Chandrakasan and Sumathi for your time today. Thank you everyone for your engagement and for joining us to talk about WAS today. Thank you so much. I hope everyone has a great rest of your day. Thank you.
Thank you, Emma.
Thank you.
Thank you, everyone. Thank you.